Florida Atlantic University, representing American College of Physicians. Pleasure to be here. Thank you.
Welcome as always. Good morning. American Geriatric Society.
Dr. Ken Spader for AGS.
And a very good morning. Thank you. America's Health Insurance Plans.
This is Bob Gluckman, Internal Medicine. I'm the Chief Medical Officer for Providence Health Plans in Portland, Oregon. Thank you for allowing me to attend. I'm representing AHIP.
Thank you, and it's our pleasure. American Immunization Registry Association.
Good morning, Rebecca Coyle, representing the American Immunization Registry Association.
Very good morning. Thank you. American Medical Association.
Sandra Freihofer, General Internist in Atlanta, Adjunct Associate Professor of Medicine at Emory, representing the American Medical Association.
And a very good morning. Thank you. American Nurses Association.
Morning, Chad Riddle, representing the American Nurses Association.
Thank you and good morning. American Osteopathic Association.
Good morning, Stan Graug, Professor Emeritus, Oklahoma State University, representing the American Osteopathic Association.
Very good morning. Thank you. American Pharmacists Association.
Good morning from Atoka, Tennessee. This is Steve Foster.
Good morning. Welcome. American Association of Immunization Managers. Association of Immunization Managers, forgive me.
Hi, good morning. Molly Howell, Immunization Director at the North Dakota Department of Health, representing AIM.
Welcome and good morning. Association for Prevention Teaching and Research.
This is Dr. Paul McKinney, Professor, School of Public Health and Information Sciences, University of Louisville.
Good morning and welcome. Association of State and Territorial Health Officials.
Good morning, Dr. Romero. This is Nirav Shah, the Director of the State of Maine Center for Disease Control and Prevention, and the President of ASTA.
Welcome and very good morning to you. Biotechnology Innovation Organization.
Good morning. Phyllis Arthur, representing BIO.
Thank you and good morning. Council of State and Territorial Epidemiologists.
Christine Hahn, State Epidemiologist of Idaho.
Good morning. Welcome. Canadian National Advisory Committee on Immunization. Canadian.
Good morning. It's Shelley Dietz. I'm the chair of Canada's National Advisory Committee on Immunization.
Thank you and good morning. Infectious Diseases Society of America.
Good morning. Jeff Duchin, Health Officer, Public Health, Seattle and King County, Washington, and Professor in Medicine, University of Washington, Division of Infectious Diseases.
And Carol Baker, I'm here, also Dr. Romero, Professor of Pediatrics, University of Texas Health Science Center, Houston.
Welcome to you both and a very good morning. International Society for Travel Medicine.
Good morning, Elizabeth Barnett, here for the ISTM.
Thank you and good morning. National Association of County and City Health Officials.
Good morning. This is Matt Zahn, representing NACHO, present.
Good morning. Thank you. National Association of Pediatric Nurse Practitioners.
Greetings, Patsy Stinchfield, representing Aetna.
Thank you and good morning. National Foundation for Infectious Diseases.
Good morning. This is Dr. Bill Schaffner. I'm a professor of preventive medicine and infectious diseases at Vanderbilt and the medical director of the NFID. Good to be with you.
Wonderful to have you and good morning. National Medical Association.
Good morning, Pat Whitley-Williams, Pediatric Infectious Disease, Rutgers Robert Wood Johnson Medical School. I'm representing the National Medical Association. Thank you.
Thank you and welcome. Pediatric Infectious Diseases Society.
Good morning, Sean O'Leary, representing PIDS.
Very good morning. Welcome. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Good morning and welcome. Society for Adolescent Health and Medicine.
Hi, good morning, everyone. It's Dr. Amy Middleman, and I'm representing SAM.
Thank you and good morning. The Society for Healthcare Epidemiology of America.
Good morning. This is Marcy Dries, the Chief Infection Prevention Officer at Christian Care, representing SHEA. Thank you.
Good morning and thank you. Dr. Cohn, that completes our roll call for this morning. I turn it back over to you.
Great. I think we can go right in and begin our agenda items.
Very good. So we'll begin then with our coronavirus disease 2019 COVID vaccines with an introduction by Dr. Matthew Daly. Dr. Daly, please.
Thank you so much. Next slide, please. So we wanted to start by providing some context to the discussion which follows. The graph below shows the daily trend in the number of COVID-19 cases in the United States reported to the CDC. In December 2020, there were approximately 250,000 cases and 3,000 deaths each day in the United States from COVID-19. And now in June 2020, there are approximately 13,000 cases and 300 deaths reported each day. There have been 3 vaccines against COVID-19 authorized under an emergency use authorization and recommended for use in the U.S. And these vaccines have played a critical role in the extraordinary reduction in case counts and deaths occurring in the U.S. 318 million vaccine doses have been administered, with approximately 150 million people in the U.S. fully vaccinated. This translates to approximately 53% of the population 12 years of age and older who are fully vaccinated, and upwards of 63% of all persons 12 and up in the U.S. have received at least 1 vaccine dose. And this epidemiologic curve of case counts stands in stark contrast to the epidemiologic curves in many other parts of the world, where vaccines are scarce and waves of COVID-19 cases and deaths have continued unabated. Next slide, please. In the time since the last ACIP meeting, the COVID-19 vaccines work group has been meeting weekly. The topics covered in these weekly meetings have included a review of vaccines with respect to SARS-CoV-2 variants, a review of data to inform discussions around additional doses of COVID-19 vaccines. We've also reviewed a number of safety updates, including a review of data regarding myocarditis following vaccination. And the work group has also had extensive discussion about the overall benefit-risk balance for the use of COVID-19 vaccines in adolescents and young adults. Next slide, please. So in today's session, we'll first have a discussion of the cases of myocarditis and pericarditis, which have been observed following receipt of mRNA COVID-19 vaccines. Next slide, please. So to frame our discussion about myocarditis and pericarditis, I'd like to raise several points related to vaccine safety. As we've heard on prior ACIP calls, the safety monitoring system put in place to monitor COVID-19 vaccines in the United States is the most rigorous system ever implemented to monitor any vaccine in the country. And there's an extensive list of potential adverse events that's being monitored. And to date, the COVID-19 vaccines authorized in the U.S. have demonstrated a high degree of safety. However, nothing in life is absolutely risk-free. And we know from decades of experience with other vaccines that rare and potentially serious adverse events can occur following vaccination. And the extensive safety monitoring systems in the U.S. should give us confidence that if a rare and potentially serious adverse event occurs following vaccination, we have the systems in place to identify that risk. And once a risk is identified, vaccine safety studies help us characterize and quantify the adverse event. And also, an understanding of risk factors allows us to minimize adverse events whenever possible. And then finally, a critical aspect of vaccine safety is communication of vaccine risks if identified to the public, to public health officials, to healthcare providers. And in this circumstance, new knowledge about vaccine safety is also used in a reassessment of the benefit-risk balance of any vaccine in use. And that is part of our task in this session this morning. Next slide, please. So the first reports of cases of myocarditis following vaccination with mRNA vaccines came from Israel. And as you can see here, from December of 2020 to May of 2021 in Israel, 148 cases of myocarditis occurred around the time of vaccination. And most of these reports, although not all, were in younger men, 16 to 19 years of age. And this was typically after the second dose. And while most of these cases were hospitalized, 95% were characterized as mild cases. And based on this, Israel determined that there was a possible link between the second vaccine dose and the onset of myocarditis in young men aged 16 to 30 years. And based on this, Israel determined that the risk of complications of coronavirus disease outweigh the risk posed by the vaccine side effects. And they also stated that myocarditis cases observed among teenagers aged 16 to 19 years occurred at low rates and in most cases passed with no complications. Next slide, please. So since April of 2021, there have also been cases of myocarditis and pericarditis reported in the U.S. to the Vaccine Adverse Events Reporting System, or VAERS. And these reports, and the reports from Israel, led to the posting of additional information on CDC's website, which you can see at the right. And we'll hear more about these case reports in the presentations today. Next slide, please. So in response to the reports of myocarditis and pericarditis following mRNA vaccines, the Vaccine Safety Technical Workgroup, or VAST, reviewed data from Israel. VAST also reviewed data from the U.S. Department of Defense and from other CDC and FDA safety surveillance systems. And then the COVID vaccines workgroup also reviewed these data and discussed the benefit-risk balance. And that has all led to today's public ACIP meeting to review these data and to discuss a benefit-risk assessment. Next slide, please. So in today's COVID-19 vaccine session at the ACIP meeting, after our discussion of myocarditis and pericarditis, we'll also begin discussion of the topic of booster doses of COVID-19 vaccines. Next slide, please. So just to introduce the topic, as we've discussed, the majority of Americans have received at least one dose of a COVID-19 vaccine. And a great deal of planning is going to be required if booster doses of COVID-19 vaccines are needed. And these discussions around planning really need to occur well in advance of future recommendations. However, I do want to point out that the planning discussions are not meant to imply that the decision's already been made, that booster doses will definitely be recommended. But today, we'll discuss what additional data will be needed to inform these future recommendations. Next slide, please. So here's a review of today's agenda. So first, Dr. Matthew Oster will review myocarditis and pericarditis, provide an overview to lead us into the discussion. This will be followed by Dr. Tom Shimabukuro, who's going to provide an update on COVID-19 vaccine safety, including risk of myocarditis following mRNA vaccines. After Dr. Shimabukuro, we'll hear what the VAST assessment is of these data by Dr. Grace Lee, who's an ACIP member and also the VAST chair. After Dr. Lee, we'll hear from Dr. Megan Wallace and Dr. Sarah Oliver, who will discuss COVID-19 mRNA vaccines in adolescents and young adults and introduce the benefit-risk discussion. And then we'll have a broader discussion among the ACIP, after which we'll have a public comment. And then after the public comment period, Dr. Sarah Oliver will provide an overview of data that will be needed to inform recommendations for additional doses of COVID-19 vaccines, and then a discussion of that, of booster doses. Next slide, please. I want to extend my heartfelt thanks to all of the ACIP members the ex officio and government members, the liaisons, and the consultants to the COVID vaccines work group, and in particular, the tremendous leadership of the CDC lead, Dr. Sarah Oliver. Next slide, please. And a really long list of tremendous CDC participants who helped the COVID-19 vaccines work group with all of this deliberation. Next slide, please. Thank you very much. I will turn this over to Dr. Oster.
Thank you, Dr. Daly. Dr. Oster will now present overview of myocarditis and pericarditis. Dr. Oster, the podium is yours.
Great, thank you very much. So good morning. I'm Dr. Matthew Oster. I'm a pediatric cardiologist at Children's Healthcare of Atlanta and Emory University, but I also work at CDC recently on the COVID-19 vaccine task force. I'll be giving a brief overview, just an introduction to make sure people understand myocarditis and pericarditis. Next slide. Next slide. All right, so first, what are we talking about when we mention myocarditis and pericarditis? So myocarditis, strictly speaking, is inflammation of the myocardium or the heart muscle. We're not talking about myocardial infarctions or heart attacks, which typically affects the coronary arteries. Instead, we're talking about an inflammatory process that involves the actual muscle of the heart. Pericarditis is a similar process, but instead of involving the heart muscle, it involves the pericardium, which is the lining around the heart. And often these two entities can occur together. They have similar mechanisms. And when they do both occur together, we'll use the term myopericarditis. Next slide. So myocarditis has been around for a long time. It's not a new disease, but there have been some updates in how we can recognize it and diagnose it. And so for the purposes of surveillance, CDC has drafted this definition that is being used. And we think of myocarditis as probable cases and confirmed cases, although for the purposes of surveillance, both are counted. And so for a probable case, first, we'll look for symptoms. Typical symptoms associated with myocarditis include chest pain, which may also be described as pressure or discomfort, dyspnea, shortness of breath, or palpitations. There can be other symptoms, especially GI symptoms or fatigue symptoms, especially in younger children. Second, a number of tests can be performed, and to make the diagnosis of myocarditis, we're looking for an abnormality on at least one of these types of tests. Specifically, elevated troponin, certain findings on electrocardiogram, decreased cardiac function on echocardiogram or MRI, or cardiac MRI findings that are consistent with myocarditis showing evidence of inflammation. And importantly, we want to make sure that there's no other identified cause, like a structural abnormality or a myocardial infarction that is leading to these abnormal testing values. For confirmed myocarditis, again, we're looking for the presence of symptoms, and then testing can either be on biopsy, so that's getting tissue, from the heart, or if you have an elevated troponin and MRI findings consistent with myocarditis, we'll consider you confirmed. And again, no other identified cause. And these definitions are primarily used for looking at clinical myocarditis, which is the primary ones that we are looking for in surveillance at this time. But I will point out that there can be subclinical myocarditis, in which case you may have some of these abnormal findings, but without the presence of symptoms. Next slide. For pericarditis, there's a well-established definition that CDC has been using, and it states that you need to have two of any of these four findings. So chest pain, and there's a certain type of chest pain that we typically see with pericarditis. A pericardial rub audible by stethoscope on the physical exam, abnormal electrocardiogram finding, or pericardial effusion on echocardiogram or an MRI. For the remainder of this talk, I'll be speaking primarily about myocarditis, since that is the one that is most concerning and most prominent that we are seeing. Next slide. So what is the past epidemiology of myocarditis? I mentioned this has been around for a long time, and we've taken care of it quite a bit. In children, we know that the annual incidence on average is about 0.8 per 100,000. But as you can see, kind of has a bimodal peak. We tend to see it a lot in infancy, and then you can have cases throughout childhood. But once patients start reaching adolescence, you start seeing an uptick in the number of cases, such that the annual incidence in this recent study was about 1.8 hospitalizations for myocarditis per 100,000 in 2015 and 16. In traditional myocarditis, there is a predominance of this affecting males more than females. And traditional myocarditis, tends to, have a length of stay of about 6 days and can range from mild to severe. There can be some kids who are quite affected in, traditional myocarditis. In adults, we similarly see that the peak incidence is in, the younger adults, and then that does decrease with age. And again, it does have, a male predominance, especially, in the younger age groups. Next slide. Now, traditionally, there are many different types of causes of myocarditis. Most typical myocarditis we think of often, has a viral trigger. A classic story would be someone who can have just mild viral symptoms, for a few days, they may get better, and then a couple of weeks later, all of a sudden start showing signs or symptoms of myocarditis as the immune system is ramped up. In a traditional myocarditis, an exhaustive search is often undertaken to look for potential causes, especially viral causes, although there are others that can lead to it. Although I will say that very often no specific cause is identified. Next slide. So how do we treat myocarditis? So for traditional myocarditis, supportive care has been the mainstay of therapy. So if they need oxygen for support or fluids if they're dehydrated, really, supporting the body's response to this. And that's kind of been the first line for post-vaccine myocarditis as well. As needed, if there are effects on the heart, such as arrhythmias or decreased heart function or congestive heart failure, specific medicines or therapies can be, implemented, for each particular case. Anti-inflammatory medicines are often used. There are a variety of them. I will say the data to support this, does vary a bit in different populations, and that includes the use of Nsaids or steroids or even IVIG, for its anti-inflammatory properties. In this, the use of anti-inflammatory medicines will vary by patient situation, by their age, or by the hospital that they are at. For most post-vaccine myocarditis, many kids have been responding to just minimal treatment with some anti-inflammatory medicine. In traditional myocarditis, in severe cases, you can consider mechanical support, or heart transplant. But importantly, in traditional myocarditis, it's been recommended to have exercise restriction while the heart recovers. The American Heart Association and the American College of Cardiology recommend, restriction from competitive sports for about 3 to 6 months until you can show documentation that the heart has recovered from this acute process. And so many places are also implementing these same guidelines for post-vaccine myocarditis, given the uncertainty. Next slide. So what do we know so far that's been published in the literature about myocarditis after mRNA COVID-19 vaccine? There have been a few reports, and I'll summarize just a couple of them here. So in the United States, there was a paper published in Pediatrics looking at adolescents, and this looked at 7 males who were previously healthy who developed myocarditis within 4 days of their second mRNA vaccine. All of these individuals had abnormal troponin levels, EKG findings, and MRI findings. And 3 of them, their symptoms improved with Nsaids alone, and 4 of them did receive IVIG and steroids. All of these patients were discharged to home after about 2 to 6 days in the hospital with a median of 4 days, and they are currently being restricted from exercise. Most recently, there's a paper by Rosner et al. Published in Circulation that looked primarily at adults. So this paper reported 7 patients, but only 6 of those were after mRNA vaccine. They had 5 males that were 19 to 39 years old who presented with 4 days of their second dose. They had one 24-year-old who presented about a week after his first dose. All of them, again, had abnormal troponin and MRI findings, and there were some varying EKG findings. Treatment with Nsaids or colchicine, another anti-inflammatory medicine, was used in 4 patients. 2 received beta blockers, which is a medicine to help support the heart when needed, and steroids were given in 1 instance. And all were discharged home after 2 to 4 days in the hospital, needing about 3 days. Now, I'll just point out one interesting finding. Since we do not know, potential mechanisms yet for, post-vaccine myocarditis, that is under investigation. But in this one case, that a patient who presented a week after their first dose, interestingly, the spike protein antibodies were negative in that patient. Next slide. There have been some international reports as well. Larson et al. Included patients not only from the United States, but also from Italy. We looked at 8 males from 22 to 56 years old. Again, a week within, 7 had a presentation within 4 days of their second dose. 1 who had onset 2 days after his first dose, and that patient had history of prior SARS-CoV-2 infection. All these patients also had abnormal troponin, echo, and MRI. Almost all had abnormal EKGs. Treatment with Nsaids or colchicine in 4 and steroids in 2. And interestingly, no treatment was used in 3 of the cases. And all of these 8 individuals are discharged home with resolution of symptoms. And the ones who had some decreased ejection fraction had preservation of their ejection fraction at discharge. And then finally, you heard already the report from the Israeli Ministry of Health, but just to recap here, they reported 148 myocarditis cases occurring within 30 days of mRNA vaccine, 27 after 5.4 million first doses, and then the majority, the 121 cases, were after the second dose. Again, these were mostly in men aged 16 to 30, especially the adolescents 16 to 19, and most were in the hospital up to 4 days, and they considered this to be mild cases in 95% of them. Next slide. So to summarize, myocarditis is a rare disease, but it's not a new disease. It's been around for a while. As I said, traditionally, there have been, thought to have viral triggers, although there can be others. But it does appear that mRNA vaccine may be a new trigger for myocarditis. Yet it does have some different characteristics in the presentation and particularly the course of how patients are doing. Treatment is largely supportive, and that has been the case for myocarditis after mRNA vaccine. And in myocarditis after mRNA vaccines, as you've seen, this is most commonly in males, which is also the case for traditional myocarditis, but whether this is even more pronounced is to be determined. It's being seen predominantly in less than 30 years old, and typically has onset within a few days after the second dose. Early data of acute outcomes of myocarditis after mRNA vaccines have been good. There's typically quick resolution. There obviously are exceptions in all things, but we are continuing to follow patients long-term. We do not have long-term data available yet, but they are getting some of these standard recommendations with regards to exercise precautions. Next slide. So thank you very much, and I'd be happy to answer any questions now or later during the discussion.
Thank you very much for that excellent presentation, Dr. Oster. This is now open for discussion. Please raise your hand, and let me lead this off with a question. Can you give us, to use as a frame of reference, what the outcomes are for myocarditis that occurs outside of what we're seeing in COVID, as in previous decades, if you will. That is the mortality the chronicity, in particular, the development of chronic dilated cardiomyopathy. Would you please give us that as a context with which to frame the current outcomes of myocarditis?
Yes, certainly. So, traditionally, outcomes, after, myocarditis were, typically a bit more severe than what we're seeing. So you saw some of the, presentations that are on length of stay. Length of stay would often be about 6 days or longer. There's definitely a higher risk of mortality or need for heart transplant and the like. Prior studies, in children at least, the risk of mortality was as high as about 4 to 7%, and heart transplant about 4 to 9%. We haven't seen, numbers that high in the post-vaccine myocarditis group for sure. So that has at least been reassuring.
Thank you. Dr. Fry, please.
Thank you. I had a similar question, and I was just wondering, we do have some denominator information in the Israeli Ministry of Health paper, and I was wondering what is the incidence over background, and I was wondering also how many of these individuals were in the military, and do we know if this is even higher than the numbers that we would see, for example, with smallpox vaccine? You may not know the answer to that third question.
I can't answer anything about the Israeli data. I know Dr. Shimabukuro after me will be giving some updated numbers on the observed over expected, at least in the VAERS reports and vaccine safety data links. I'll defer to him for those reports.
Good. Okay.
Thank you. Dr. Pelling.
Hi, thank you very much for this great presentation. One of the things that was mentioned several times was about the acuity of myocarditis, and we've been talking that these are relatively mild. Could you provide some more information about historically what is the range of, we talked about there's mild, moderate, and severe. Do you know relative before COVID-19 how many occurred in the mild cases, and then what we're seeing now? Do you have any insight into what do we mean by mild and what is the long-term prognosis?
Okay, so I'll answer that in two parts. So first, in terms of the exact numbers, we can get back to you on just how things are different, and we're still learning a lot about some of these current cases. I did want to give that, caveat. Many have been reviewed and investigated, but not all of them as of yet. But the clinical course for sure seems to be, a shorter clinical course in terms of length of stay, and the treatments that are needed do seem to be, more minimal. And we had, certainly there are cases like that can happen traditionally, but we don't see as many as the more severe presentations or severely affected. But again, there can always be exceptions. Now, in terms of the long term, I will make the point that even in classic, kind of myocarditis, those recommendations from the American Heart Association, American College of Cardiology, they make a point of saying that those, recommendations for refraining from exercise, it doesn't really matter whether it was mild, moderate, or severe. It applies to all. And the rationale for that is, even after symptoms improve, you can still have some inflammation of the heart and eventual scarring of the heart, which, could be adenitis for, some arrhythmia or other concern. So making sure that the heart fully recovers. One of the, biggest identified risk factors for that isn't necessarily the severity of the clinical course, but some of the MRI findings that have been seen. But also, for sure, if you have history of prior, arrhythmias or other, concerning, can play a factor into that as well. But since some of these kids who even have what we're saying a rather benign clinical course have some significant MRI findings, we do need to follow them closely just to ensure that their long-term outcomes are good as well. I'm very optimistic that they will be, but we do not have any data on that yet.
Thank you. Dr. Bernstein.
Thank you for building a foundation around myocarditis and pericarditis. I was interested to hear whether you see any similarities with the possible pathophysiology of these episodes of myocarditis after dose number 2 and the cardiac findings associated with MISC.
Excellent question. So, I'll address that, and I also want to address, because, there's some people were asking about smallpox. This is a little bit different just in the presentation after smallpox. I wanted to mention in terms of the timing after the dose. So it's hard to say anything about the mechanisms, because we don't really fully understand the mechanisms for MISC, or for this one yet. It's being certainly evaluated. I will say these kids, though, they look very different than the kids that we take care of who have MISC. We're certainly concerned about heart function in both cases. The kids with MIC, they just look sicker, especially when we've seen more severely affected ones. But we're still early on, in understanding this myocarditis. So it's hard to really compare the two. I will say the kids with MIC tend to often have, other systemic findings that we're not seeing in the myocarditis group. They can often have, pretty severe abdominal pain and gastrointestinal findings. They can often have mucocutaneous findings, especially conjunctivitis. They can often have rash, neuro findings, and some other abnormalities. The myocarditis kids, while they can have some GI findings or other things, it often seems to be primarily the heart being affected and then other things being secondarily affected, which appears to be a little bit different in the MISC kids. Hopefully, as I mentioned, we don't know the long-term outcomes of this myocarditis group, though. We do know a bit of the long-term outcomes of the MISC group. There have been some papers published which shows that even those who've had some pretty significant heart involvement, they're tending to, look really good at 3 to 6 months for those who have had MRIs and those who've been followed up, at least from a heart standpoint. But certainly more follow-up is ongoing both in that group, and hopefully will be happening in this myocarditis group.
Thank you.
Thank you very much. Dr. Daly.
So I think in some ways we're all asking sort of similar questions from different angles, and this is sort of another in that. But my sense was that sort of as a single measure, something like ejection fraction on an echo is a useful indicator of severity. It's sort of the heart squeeze or strength of the heart squeeze. And so what was the ejection fraction for these individuals who have reported cases? And then sort of what does that also tell us about sort of at least what we'd anticipate long term? Thank you.
Yeah, so again, I think of, acuity and severity, we think of, the short term right now and then the long term. So, for the short term, there have been some cases of function being, down a little bit lower than normal, but most have had preserved function when they present and have had normal other measures of function typically, and that's, most commonly brain natriuretic peptide or BNP. So, but it can happen. You can have some decreased function. As I said, the good news so far is that function tends to rebound rather quickly, and it just appears anecdotally, and we haven't done formal comparisons, but this appears to respond more quickly than kind of your classic myocarditis, so that's reassuring. Long term, though, we'll have to see. As I mentioned, those AHA and ACC guidelines, specifically state that they don't take kind of your heart function into account really when trying to determine long-term restrictions or not. Although that can be a risk factor for some worse outcomes in those with myocarditis. And so that's part of the reason also again why I'm optimistic they'll do well, because during the acute phase, the function again, as I said, is not as affected as in classic, but it can be. But when it is, it does seem to respond rather quickly.
Thank you. Dr. Lee.
Thank you so much. First of all, I just want to thank you for sharing your expertise with us and also for your leadership of this effort as investigations are underway. We really appreciate your contributions. I wanted to ask a little bit about of the cases of MISC that I've seen. There are sometimes cases that don't meet the classic definition of MISC either. And wondering if you can comment on, the impact of COVID-19 infection on the heart that, in cases that don't necessarily meet all the criteria for MISC, and if you have a, clinical sense of what those cases look like in general.
Yeah, so certainly there's been a lot of concern about how COVID-19, may affect the heart. Interestingly, from a clinical standpoint and what we're seeing in the hospital or clinic, primary heart involvement reaching clinical concern is quite rare. The biggest concern has been MISC, at least in the adolescent population. But we have seen certainly more, myocarditis in the older population, or adults and older population. But there has certainly been concern, and there has been some good, papers published on this on potentially subclinical myocarditis, and that if you start looking for it, you start noticing things, of COVID affecting the heart. That's certainly an area of concern and something people are looking at more.
Thank you. Dr. Sanchez. Dr. Sanchez, you may be muted.
Hi, thank you. Sorry, Jose. Thank you for the presentation. I guess I'm just thinking about the mechanisms that could be involved. It was interesting that you reported one patient who had the myocarditis after the first dose, and he tested negative for the spike protein and for the antibodies. And I was just wondering, has anybody measured by PCR the spike protein by PCR in blood? And in any of these patients, I have not seen them in the case reports. And is anybody looking at that to see whether, I would imagine that after vaccination, one can detect at least transiently the spike protein that's being produced, and whether it has any relation to some of these individuals not clearing it or any differences. I have not seen that reported.
Yeah, so there was one case report, and I'll direct you to that if you want to learn more, that investigated, possible mechanisms for myocarditis after vaccine. It was published in the past week by Mutha Kumar et al. In Circulation. And it was one case, it was an older gentleman who's, I think, 52 years old. But they did a lot of testing to look for potential mechanisms and have some hypothesis testing. And, I believe they, tried to look at some more quantitative measures, which you can read there. There have been a number of proposed things that people are looking for. What is the mechanism? Is it something antibody-mediated? One leading hypothesis I'll say that people are thinking of is, could it be some sort of, cytokine response, especially given the kind of relative rapidity of developing myocarditis after that second vaccine. Certainly an area that warrants further investigation and understanding.
Anyone investigated whether the blood by PCR is positive in these patients versus some others?
Oh, yes. So in these patients, looking for at least active COVID infection or evidence of prior COVID infection with nucleocapsid antibodies.